First of all, thank you all very much for coming. I'm Ken Ottenbacher. I'm Director of our Division of Rehabilitation Sciences here at UTMB. And we have a special guest today, Dr. Janet Bettger. Dr. Bettger is joining us from Duke University. She came to Galveston for the wonderful weather. I'm telling her that it's like this every day in Galveston. But before I introduce her, I wanted to just say a little bit about this lecture series for those of you who might not be familiar with it. So this is a lecture series that's part of our Patient-Centered Outcomes Research program that's related to a grant that is just about a year old now. And we have this lecture series every Wednesday at 1 o'clock, but it's usually in another room over in Rebecca Seeley. Every Wednesday except one. There's one Wednesday out of the month. Is it the second Wednesday? Okay, so the second Wednesday we have an administrative meeting. But for those of you who are interested, and I'm telling you this because one of the things we're trying to do is to just raise awareness and interest about patient-centered outcomes research on the campus. So the lecture series is primarily the people who are involved in the grant, but it's open to anyone. And the lectures are held in the classroom on the 5th floor, which I don't remember the number, but in Rebecca Seeley, 3 Wednesdays out of the month at 1 o'clock from 1 to 2 o'clock. So anyone who's interested is welcome to come to those lectures. And Stephanie, why don't you raise your hand? Stephanie's the one who is sending out the announcements. If you'd like to be on the mailing list for the lecture series, email Stephanie and she can let you know. Now, the usual lectures are internal people, people from UTMB who are talking about patient-centered outcomes research that's going on here on campus. But we've initiated this program of having external speakers who are going to come and talk to us about patient-centered outcomes research. And that brings me to Dr. Bettger. Yeah. So Dr. Bettger is an assistant professor in the School of Nursing at Duke University, and she's also a senior scientist in the center, what's the center that you're associated with as well? Okay, no, I actually have it written down, so that's what happened. I should just use the thing I've written down. So senior scientist for the Duke Translational Nursing Institute, which sounded very interesting to me. And Dr. Bettger received her baccalaureate degree from the University of Western Ontario in Canada and her master's degree from the University of Wisconsin in La Crosse in therapeutic recreation. And then did her doctoral degree. Her doctoral degree is a Doctor of Science degree in rehabilitation science at Boston University. And then she did a postdoctoral experience at the University of Pennsylvania in neurological rehabilitation. And since she's been at the at Duke University, she's been very successful in her research career. And her research career is focused on, I left out an important part here. When she was doing her training, she received a couple of awards. One of them was the Mary Switzer Fellowship, and this is a fellowship. It's a very competitive fellowship through the NIDR, which is the National Institute on Disability and Rehabilitation Research. And she also received training as a mentored scholar in comparative effectiveness research funded by the AHRQ. Her research is focused on healthcare quality in older adults with chronic conditions, particularly stroke. She has an extensive publication record for an assistant professor with articles in high-impact journals, including Stroke, Neurology, and the Annals of Internal Medicine. She is a PI on a Patient-Centered Outcome Research Institute Award. That's PCOR, and that's one of the reasons we're interested in having her come. PCOR is a new institute that was created with the Affordable Care Act, and there are relatively few people who have PCOR grants, and Dr. Bettger is one of those. And that grant is designed to study the comparative effectiveness of rehabilitation and post-acute care services for survivors of ischemic stroke. She's also funded on a couple of other NIH projects that are related to examining inpatient rehabilitation outcomes. And one of the things that I found most fascinating is that she has funding from the China Medical Board. So those of us who have been doing this for a long, long time have gotten grants from a lot of different agencies, but I don't expect that ever in my life I'm going to get funding from the China Medical Board. So she has funding from the China Medical Board, and she's a co-investigator on a project that's called RECOVER, which is a trial in China, a randomized controlled trial of early supported discharge and translational care in rural China. Now, I don't think she's going to talk to us about that today, but that would be an interesting topic for her to come back and do another presentation on. Today, she's going to talk to us about aligning national priorities with stakeholder input to improve healthcare quality and outcomes. Please join me in welcoming Dr. Bettger.
It's an honor to be here for a lot of reasons, and first and foremost because I've been following the careers of many of the people in this room for several years. So to be here and actually be invited to speak when I'd like to actually spend the day and hear more about other things that are happening here is a really exciting experience for me. When I first got the invitation to join all of you, these were some of the things that were thrown around in the emails. A little bit of an alphabet soup. You know, they're all really big, hot topics. PCOR, Patient-Centered Outcomes Research, CER, Comparative Effectiveness Research, HTA, Health Technology Assessments, and D&I, Dissemination and Implementation Research. And I think one of the emails was, well, you can speak on any of these or all of these. I was like, okay. So I'm going to integrate the work that I do actually in all of these areas under the umbrella of how we have found it so helpful to link the work that we do to national priorities and to stakeholder and patient engagement in the work that we do. Because ultimately, the reason why we're doing this research, or at least for me, is to improve quality and to improve outcomes. And to be able to have the people that we're doing this work for involved from the very beginning has been so much more meaningful, at least for the work that I do. So we're going to go on a little journey together. I may speak a little bit fast in part so that I can allow some time for interaction at the end, and really here just to be able to get through the points of how I've been able to, with my teams, explore stakeholder input, the linkage and how it converges with national priorities, and really being able to target these deficiencies in healthcare quality and outcomes. So, in this room, has anybody been to London? Oh, many of you have been to London. So my first time in London, I had never, you read about things that you want to do when you get to places. And so my first time I thought, okay, I want to be sure I go on the Underground. And what was so fascinating to me when I went on the Underground, so from a public health perspective, for me, the train system was different in mass, and I was glad they sold t-shirts and mugs with it on there. But what was so intriguing from a public health perspective is there are several places in London where the trains, now trains are straight and flat, where the trains actually have to go around a curve underground. Now, if you have kids and you see your train tracks trying to go around these curves, sometimes they fall off the tracks. Now, you can't exactly do that, right, when you're in the Underground. So these trains are essentially trying to go around a curve, and they've built these platforms appropriately to mesh them, but they're not exactly straight trains, and they have this massive public health intervention called Mind the Gap. So this is now 45 years old. And they started it as a communication system to warn people as they were getting on the trains in the London Underground to mind the gap. And it became so important and recognizable that this is now expanded to 60 plus countries and I don't know how many different languages to warn people that you're about to cross this threshold from something very safe, cement on the ground, into a almost moving train, and to mind the gap because you could potentially fall, get caught, whatever, as you're crossing forward. So having done training in rehabilitation and in public health, I find it fascinating that we can think about some of the lessons they had 45 years ago now in transportation and how we can translate that to healthcare. Because this is my most recent, I take pictures of these signs everywhere I go, so this one's from Beijing in March. But what's so fascinating is what they were able to do with this public health campaign and being able to be sure that they communicate clearly, they have it posted, it's you hear it, you see it, it's warned, they have, they changed the texture of the platform before you get on the train. And should we not be thinking to do that a little bit better in healthcare? We're essentially discharging people from our inpatient settings to the community with no warning, in many cases, about what they're about to face. And so I think about this a lot because the gap here, and we face it a lot, particularly in the rehab settings that we work in and in our post-acute and ambulatory care, as we're seeing people come out of acute care, they have gotten many times very little preparation, very little warning about what's to come, particularly in those first 48 hours to a week after hospitalization. And we really should have some kind of intervention here to address the gap. And so I think all the time about this, and every time I get now on different trains, I'm thinking, there's got to be a better way to do this. And this has a lot of times reminded me in my research of how we need to be better communicating and thinking about the work we do and bringing that back to the reason we're doing this, which is for the patients and what we're finding and how to be able to communicate that back to them. So the lessons we have from transportation and public health to healthcare and how we could better address this. So my focus in research has been this gap. For almost 20 years now, I guess, has been this inpatient to outpatient gap. So being reminded today about the work I did in therapeutic recreation, we were joking at lunch, I used to, before prospective payment, I used to train people and test them in the community before they left rehab or before they left the hospital. You know, we used to get paid for that. You used to be able to get them on the bus, get them on the train, you know, be able to test their pathfinding skills. And that's what I did from, you know, really large trauma facilities, and we don't do that anymore. But imagine if we could set healthcare up like that. Here's where we are today, though. National priorities are very focused on this transition. We have HHS, the Health and Human Service priorities around the triple aim, focused on better care, better health, lower costs, with a strong focus on care coordination. So these 6 national quality strategy priorities, the care coordination one actually resonates almost through all 6. CMS has made a very strong statement about wanting to, now this should have expired actually at the end of 2013, reduce healthcare acquired conditions and readmissions by 40% for HAC and 20% for readmissions. So a strong commitment at a national level to focus on the transitions and this gap, but yet the work is still underway. We have a lot of work still to do, so it's an exciting area of research right now. So from a national priority perspective, there are a lot of people focused right now on these gaps between settings and how patients transition across the care continuum. Where I've been doing most of my work has been in the area of stroke. So just as an overview, some of you might not be working in this field, but there are almost 800,000 strokes a year. Outcomes are not always positive, so about every 40 seconds. So we've already had about almost 15 strokes since I've been standing here at the top of the hour. Every 4 minutes, someone dies of a stroke. 1/3 are almost permanently disabled, and this one's so striking to me. Stroke survivors requiring constant care 3 months following their stroke have a 7-fold increase in 1-year mortality. So we have a significant commitment to be able to look at this population, in part because from a healthcare perspective, that means we have almost 1 million hospitalizations a year that we're discharging, and with what guidance? With what evidence are we using to guide that critical decision prior to discharge to say, these are the services you should be getting for who you are and your level of impairment. This is how we should be training you and your family. These are the interventions you need. These are the medications you need. So we've really focused on, and the teams that I've been working with have really focused on this critical point of intervention, this handoff from acute care to post-acute care. And the reason why I've become so intrigued specifically with strokes, even though we had this discussion about the need to really understand the broader populations that receive post-acute care, what's so interesting with stroke is the number of people who actually use post-acute care compared to the larger population of Medicare. So when we look at all Medicare beneficiaries who have fee-for-service Medicare, we see that about 35% go on to receive post-acute care in either an inpatient rehab, skilled nursing facility, an LTAC, or home health. But for stroke, it's twice that. So we have a population of really sick, vulnerable adults who are facing this gap much more often with even less evidence because of the work that hasn't been focused specific to this population. So we have the transition from pre-hospital, they call 911, they ideally would be brought to a hospital in an ambulance and are treated acutely in the hospital. A lot of work, most of the work, the majority of work in stroke has been up to this point here. Very little has happened from this point forward, which is why we're seeing these people drop. And when we think about the amount of research that has happened from the point of the stroke to discharge from the hospital, that average length of stay is 4 days. 4 days in this country. We've got the rest of the person's life to think about. A significant significant gap when you think they're continuing to receive services, healthcare services paid for, at least for in Medicare, this is Medicare analysis, up to 109 days, so at least another 3 months. They're still kind of connected to the healthcare system. They're bouncing around, so whether you want to call them handoffs or transitions, they're not just receiving care in one service, they're receiving care in multiple services and being handed off across different providers. We're seeing at least 1/3 of them back within 3 months. And then within 6 months, at least 1/3 of them are ending up in a long-term care nursing home residence type place. So the areas that I've decided to focus on since thinking back to the 90s when I was really interested in community reintegration has been zeroed in down to these two areas, including the work that I do in China, actually. What services should a stroke patient receive after being hospitalized for a stroke, given who they are and how are they recovering at that point, and what strategies should be in place to improve the transition from inpatient care and to improve longer-term outcomes. All right, so how does this link then into PCOR, Patient-Centered Outcomes Research? The translation ends up being how we bring patients into this continuum of these studies. The first being comparing post-acute and transitional care treatment options. So I do both of these areas of research. So comparing first post-acute treatment options that matter to patients and to their caregivers, comparing transitional care strategies that matter to patients. So it's not something that we're saying they have to get or they should receive, but that it's meaningful and important to them. And secondly, that we're focusing on outcomes of interest to them. And this has been a debate for years. I remember even before I'd gone back to grad school debating with physicians in the Massachusetts Medical Society, where they were so bent on being sure that mortality was being reported for every hospital, back to when New York State was reporting it for CABG, and thinking, well, this should be publicly reported for every hospital, for every condition. And we're like, mortality, think of where we've come in the last 15 years. I mean, mortality is not the prime outcome that we're interested in. And so really being able to understand, particularly now in the area that I'm doing with stroke, and many of you that are involved in rehabilitation or gerontological research, there are many more outcomes beyond mortality that patients are interested in wanting to learn about. So how do we study these areas, really being focused on patients? So this first area, the comparative effectiveness of rehabilitation services, as was mentioned, is funded by PCOR, and I was really fortunate to receive that on the first round in that we were able to describe that there are so many options after a hospitalization of where patients go. And this is the kind of the UB92 billing sheet that people fill out of, check the box of where people go after they're in the acute hospital. But we know as we look at all of these that there are some that are much less common, particularly for stroke. And so when we zero in on where people are actually going and the services that are more common in this population, we have a group of people who go on to receive short-term inpatient post-acute care, and there are about half that go directly home. When we focus then in on what services they're receiving in those kind of two first trajectories, of the ones that go to short-term inpatient post-acute care, the most prominent types of services are either an inpatient rehabilitation facility or a skilled nursing facility. So in this country, at least for stroke, LTACs are only used in about 2 to 4% of the population. So the primary focus, at least that we had positioned to PCOR, we said, let's be sure that we understand those that are most common, because these are the services around the country that patients are ultimately needing to decide between. They're needing to decide between an inpatient rehab facility or a skilled nursing facility, and how do they make those decisions? The second piece that we had described and worked with our patient and caregiver groups and our stakeholders was, when you go home, how do you know what services you should get? And many of the patients said, well, people tell us. We're supposed to get home health, or we're supposed to get outpatient. And then we had asked, well, what does that mean to you? Well, they told us that we should, because they're the providers, and they told us that's what we should get. And it was really interesting to begin to hear from a patient and family's perspective their interpretation of how these decisions were being made, because as we see here, there's a larger proportion of people going directly home to receive home health, about half of those getting outpatient rehabilitation, and then there's a group that don't get any services at all. So was that their choice? Was that just how it ended up happening? And it was intriguing now to be able to be studying these outcomes for the people that were learning and going back to say, you didn't choose inpatient rehab. Well, no, that wasn't recommended to me. I was discharged home. And so when you went home, were there things that you needed? Did you have questions? Oh, well, sure there were. Well, who did you ask? Well, I had nobody to ask. And so we begin to wonder, well, these decisions were made. Now, this is retrospective data, as I show here from 2006 to 2008. Every time we do a level of analysis in this PCOR study, and we bring this back to our patient and caregiver groups, and we talk about what that was like in the process that they had experienced, they're like, well, a lot of times, we left the hospital and we didn't even get a number. We'd call our primary care office and we can't even get an appointment. And we would tell them we had just had a stroke, but nobody can see us. And we don't have an appointment to see a neurologist for 30 days, and they didn't know what a physiatrist was. So it's really intriguing to hear, as we start to think about how we're going to be analyzing these data and the experiences they had, when we first showed just kind of the distribution from the rest of the country, the stories that had begun to be shared about how the decisions were made, and people that had started in a skilled nursing facility that said, oh, no, I can't be here, I need to go to an inpatient facility, and how family had to advocate for that. And yet when we look at the discharge characteristics, you wouldn't have been able to, these two patients that went to different facilities on paper would have looked the same. But their experiences were different, what their families had chosen were very different. So when we looked across the continuum of care for the first 120 days, this almost made me stop research for a week. There were 3,000 unique patterns and trajectories, 3,000, in just 153,000 patients over 2 years. So when you talked about building episodes and what these looked for, I actually took a break after this because I thought, how do you study 3,000 unique patterns? What do we say back to the patients who are down this trajectory of going hospital, skilled nursing facility, hospital, skilled nursing facility, hospital, skilled nursing facility, home health, skilled nursing facility, hospital, skilled nursing facility for 120 days. And it was so incredible. And when we had showed this, and some of these were only 1 and 2 people, but still these were people. And I think that was the message we needed to keep bringing back to the researchers on our team and to the stakeholders from these larger organizations. They're always like, oh, it's less than 1% of the population. Okay, yeah, it's less than 1% of the population, but if this had been your mother, what would you have done? And it's really intriguing to be able to have that discussion of how do we begin to discuss that this shouldn't be happening, or we need to find a better way to identify patients who are potentially headed down that trajectory. 3,000 unique patterns. I didn't know what to do with it. And I struggle after I get to about 16. So from short-term inpatient rehab, this is just a snapshot of those that are most common. Of the people who went to an inpatient rehab facility, what we see here is it's really common to continue after an inpatient rehab facility to get home health or outpatient, that's the HH or OP. And in a skilled nursing facility, if you go there first, same thing. It's really common to get home health or outpatient after. And we were a little surprised to see the high proportion of patients who go from inpatient rehab to skilled nursing facility, because we had always been, at least when I worked in rehab, that was kind of a discouraged trajectory. You didn't want to be discharging from an inpatient rehab to a skilled nursing facility. But now that I sit with these rehab facilities, they're like, oh, we do it all the time because we know it's going to get paid for. I'm like, well, I'm not going to write that in a manuscript. So how exactly do you justify that? They're like, well, we max out their stay here and tell them that they need continued care, and then we refer them on to a skilled nursing facility so they can max out that care. I'm like, okay. I'm still working with how to best describe that one, because again, this, from a policy perspective, this means something different than what it means clinically. From a patient perspective, they've now received continued care. The family's excited in most cases, right? They understand they can't continue to receive inpatient rehab. They're going on to receive the highest level of rehab that's available to them. That's great. The families consider this almost as continued respite because they're not ready to take this patient home anyways, right? And they can now get continued training. It's been an amazing exploration with people to better understand how these decisions are made that we can't get necessarily out of our clinical and administrative data. Same thing of the ones that go home. There were some more common trajectories, and the bigger question for us ended up being how, or for these 50% of people that are going directly home, how are we linking in and connecting with primary and specialty care? With Medicare, it's a little bit better because that first visit is paid for. We've done this work on a larger scale that I'll share a little bit later, and these appointments aren't even being made when they leave the hospital. It's anywhere from 0 to 30% of the time that they're being made. That somebody is being asked to be seen after they've had a stroke. So what we originally thought as being one critical intervention point, which was after they leave the hospital, we've now identified several others. You know that there are intervention points between post-acute care settings, and we need to find a better way to study those, and as important, the discharge from inpatient rehab and from skilled nursing facilities to home. Very little work has been done in that area. And also a significant gap. So what we thought was one intervention point. We now have many intervention points that we need to continue to explore, both of the existing data and prospective intervention studies. So we had described this initially as our tremendous opportunity, and you're so fortunate to have such a rich set of data here in this institution as well, where we were able to discuss, at least with the PCOR reviewers, and make our case that We needed to be able to generate this key evidence to be able to guide this critical decision that happens in the acute hospitals almost 1 million times a year. Because right now it's being made with very little evidence. What services should they be choosing for which patients as they're leaving an acute hospitalization? So we had several specific aims, and I think as I described the first one a little bit, but we're comparing high-intensity rehab in an IRF compared to a SNF. We're comparing outpatient to home health and for which patients who should receive what, and what about the ones that don't get any, how did they fare and why, and also comparing primary care to neurology follow-up and how those factor on outcomes. So all of these are set up as comparative effectiveness studies, meaning that we're looking at, right now, we don't know which one is better for who, and we're comparing one to the other on several outcomes. So who are we studying? So this study is using, I'm not sure why that's gray, I apologize. There we go. Study is using existing data from 2006 through 2008 with a year or two of follow-up. We moved it back, so this was all pre-healthcare reform. There were a lot of changes that started rolling out in 2010. The person had to be treated at a Get With the Guidelines stroke program hospital. So what this means is that we have linked data from Medicare fee-for-service to the largest national clinical registry in this country that's at about 2 million stroke patients from over 1,800 hospitals. So to be able to have that clinical data linked to administrative claims data, and then we have cohort follow-up data in a smaller prospective study from Avail, where we have patient-reported outcomes for a set number of patients as well. So it provides a really rich integrated data set from different sources, about 7 different sources, to be able to look at several outcomes. These are very common for people working with administrative claims data to look at hospital readmission, time to readmission, long-term care placement, survival, home time, and healthcare utilization. Those are the ones that I think most people are able to most commonly identify when we say we're using Medicare data. What was so intriguing, especially to PCOR and some other funders, has been using the patient-reported outcomes, because now we'll be able to really drill down, and this is where, of course, our patients and our caregivers were most focused. They said, it's great that you can tell us we're not going to be readmitted, but you know what we're interested in? Not any of those things. Right? So when we got down to it, and they didn't understand the measures, like what is a PHQ-9, and what is a FIM, what's a modified Rankin. But as we talked through what these different things were that were measured, they very easily ranked which ones were important to them and why, and what it meant to them, what it meant to their families. And so from the patient perspective, we said there's a lot of research being done right now on TPA and stroke. They were like, that's great. Somebody's billing about $3,000 for that. If we get it, we're really lucky. And if we didn't make it in time, we didn't benefit. So we talked about early rehab and early mobilization. So for example, not being able to get a PT consult by the 3rd day of your hospitalization, you're now fatigued, you get discharged to a SNF. They're like, yeah, sometimes that happens. We understand we may not be sick. We described the cost implications, and that really wasn't so important. And we talked with patients and families about, okay, well, some of you were able to actually walk prior to hospital discharge. There was kind of this goal, climbing stairs. You went home. You received home health around the clock. And this is about how much it would cost to have, at least in North Carolina, home health 24 hours a day, 7 days a week. They're like, yeah, but at least we'd be home. But you know what we really want? We want to be independent at home. And to them, that was priceless. There wasn't anything that we could have given to them, that we could have focused on more importantly for the groups that we had surveyed and met with. For them, independence at home was their focus. And it was consistent among the groups that we had gone through. Of course, they ranked the other ones. Different people had different rankings. But independence at home was 1 and 2 among the hundreds that we had gone to. We have a very invested stakeholder group in this research that we convene quarterly for the PCOR research specifically, and I'll talk about how that's kind of swelled since. So we've been funded since, we're coming on our 1-year anniversary the end of this month. So we have working with us, our blue group on the inside is our research team that meets every week. And some of you may recognize Pamela Duncan as a physical therapist, PhD interventionist. Cheryl Bushnell is a really acclaimed stroke neurologist, just published the Women in Stroke Guidelines. And I also worked on the risk adjustment and stroke guidelines from AHA with her. Ying has done a lot of the work on TPA and thrombolytics and Joint Commission hospitals on outcomes. Eric Peterson is the director of the Duke Clinical Research Institute and very well funded and acclaimed for his work in comparative effectiveness research. And this, other than me, is the statistical team. When you think about the need for research, for resources and people coming together on what is the best way to analyze these data and better understand and activate the questions that the patients particularly and the stakeholders are having, it has been great to be able to have so many people at the table to think about what are the different ways we could be analyzing and presenting these data, because as we go back to our stakeholders, they're ultimately going to be our voices for how to best disseminate this. So we have representation from the CDC. I've been working with her for over a decade, so she was very excited to finally see this work get funded, because we've been talking about it since about 2001. And through that, we have a network to all of the funded state health departments that have are funded for stroke programs, either in primary prevention or around quality improvement. And there are 11 states that are funded. So we have an automatic dissemination network, and they've been very engaged. The Northeast Cerebrovascular Consortium has been our kind of pilot home. So when I was on my K Award, we did a lot of the pilot work for this to be able to build into the larger proposal. And they continue to do pilot testing of things that we find are meaningful, and I'll describe some of that now after the slide. The American Heart Association, as an advocate, also as a dissemination source, we're also looking at them for continuing education as these findings come out, but also they're also the leads for championing the clinical registry, so they've been very involved. Representation, from the Association of Rehabilitation Nurses and from the American Public Health Association community health nurses. So what does this mean to the nursing community, and how do we best leverage those communities to share these resources? Physiatry, the VA is going to be a great point of dissemination on a potential opportunity to influence policy, and survivors and caregivers. Now, what you see is there are survivors and caregivers on the inside and on the outside of our circle. We have targeted patients and caregivers on our advisory committee that are constantly reviewing our results, working with us on papers. They were involved in the design. But we also have groups of stroke survivors and caregivers that we kind of use as our sounding board as we're thinking about new ideas. So larger groups of that are not necessarily signed onto the research team, that we just bring ideas to, or I'll bring up like the last big policy thing that hit for the IRFs and SNFs around payment. I immediately went to the group that day and was like, did you hear about this? And we talked about it and tried to get where they were on what that meant to them. So they sit on both sides, from the inside out and from the outside in, and it's been a great collaboration that way. What we've been able to do is use our PCOR funding, and we have another stroke PCOR funded group at Duke in stroke as well. We've been able to use these groups to leverage other research projects, and that has been really helpful, because there's only so much we can do with existing data. And there are a lot of questions, particularly as we submit papers, we'll recognize in the discussion section there's a limitation. We didn't have data on this, or we couldn't answer this question. To be able to get at the issue of critical decision, a lot of people say, well, you don't have what was happening in the decision. What were the physicians saying? What was the discussion? So we've had several other side studies, many of them through the Northeast Cerebrovascular Consortium, improving assessment needs during acute care, factors influencing decisions. We've done a lot of survey work, patient and caregiver experiences, a lot of documentation there. Methods to improve scheduling, I'd mentioned that one around follow-up appointments. Linking additional data sources has been fantastic. I think one of the few limitations from PCOR's review perspective was, well, you're focused on Medicare patients, so you're only focused on 65 plus, and you're only focused on fee-for-service, so that's only about 70% of the Medicare population. We said, we acknowledge that, but it's 70% of the older adult population, and stroke primarily is among older adults, and we had addressed it, so it was what it is. This is what we're proposing. What we've been able to do, though, having the infrastructure and the design already set up, we've now been working with different states to be able to set up networks to be able to use other data sources. So in North Carolina, we worked with the state health department and the University of North Carolina, that houses many of these data sets, to link in insurance data, to link in Medicaid data, to link in health system level data. In New York State Health Department, they did the same thing. They have a Sparks database, again, that has outcomes and health service utilization for everybody in New York State, not just for people that are Medicare beneficiaries. So we've been working in state networks to replicate the design across age groups and across insurances. So that's been really fantastic to be able to think about how do we then link clinical registry data with administrative claims, but not restricted just to Medicare. So we're building those networks to be able to look at those. So soon we'll have clear evidence of what services we hope to propose for specific patients, but how do we then support them back on that journey home? And this is the work that has largely been stimulated, that had to be prospective and interventional in the area of transitional care. So I'm going to move a little bit from PCOR and CER to HTA, which was health technology assessments, to D&I and CER, so more of the alphabet soup. There are several gaps identified from people on the patients, providers, and we continue to do this gap analysis just to be sure that things aren't changing and we're not missing things. We have definite gaps that we know we need to better address on the inpatient side, and we have definite gaps we know we need to better address on the community side. But what we're trying to address specifically with this area of research is how do we get people from the inpatient side to the community side? There's a whole body of work that is really, I was going to say blown up, really in the last 15 years around transitional care. And transitional care has been getting a lot of press primarily because of the focus on readmissions. There's a specific call for it under CMS right now. There are specific funding streams. There are targeted programmatic efforts. There's a lot of work being done in this area, but what we wanted to know is, well, is it effective for stroke? Transitional care in and of itself is a set of actions that is meant to promote coordination and care continuity, either across different levels within the same location or across different services. So it's really applicable to this hospital to rehab to home population, and very applicable to stroke, because here we have 70% of stroke patients, or 70% going on to receive post-acute care. So it's meant to be supportive during these handoffs. It's supposed to be time limited, so there are a set of interventions that don't continue on forever, so it's not like disease management. Focus on continuity. Most often the models have been led by nurse, but not always. There are pharmacy models, social work-led models, but it is really being kind of the cornerstone now of coordination, care coordination. We know that there has been a lot of research on, well, what are the effects of poor handoffs? And not so surprising, there was actually a specific call out in healthcare reform focused on care transitions because we knew that there was so much work we could do and needed to be doing. So fortunately, the Centers for Disease Control saw that and had recognized that coming down the pike were going to be policy changes that were going to impact payment. Now, we all know that back in about 2010, the first wave of policy changes and the reimbursement was about to change for heart failure, pneumonia, and for heart attacks. So if patients were readmitted with any of those three conditions in 30 days, those hospitals weren't going to get paid for it. Centers for Disease Control realized, I don't think we have the literature we need and the evidence we need to be supporting interventions, particularly for MI, but we don't have it for stroke either, and stroke's likely the next one coming down the pike. So the Centers for Disease Control actually commissioned an HTA, a health technology assessment. They put money in through AHRQ that we competed and received the contract for to specifically look at transitional care for after hospitalization for stroke and MI. Where was the evidence currently for transitional care? Do we have what we need? So it was this CDC commissioned systematic review, and we did the best that we could with the evidence that we had available and disseminated it internationally. It actually picked up quite quickly, recognizing that this gap is not just a US gap, right? This is a global issue. We are discharging people, and this mind the gap perspective in healthcare is happening around the world. People are leaving hospitals without the guidance that they need. There are many transitional care models. So those of you that are working in acute care or have been following any of the press, these are thrown around all the time. Bridge, Boost, RED, transitional care model is TCM. Care transitions, this is Eric Coleman's pillars. That's why I always put them in pillars. The Interact model, STAR. There are so many of these models out there. Some of them get more press depending on, most recent study, how many people or how many hospitals are implementing at the time. And what we learned was, well, collectively, when you look at them, you couldn't actually compare them. Systematic review after systematic review kept telling us that we didn't have the evidence we needed. We didn't know which intervention was going to make the biggest difference, and that ultimately, we didn't know who they would help best. We had these trials. They were done as randomized trials for a very heterogeneous population. They were multi-component interventions that weren't powered to look at any one strategy specifically. So now we didn't know what we should be implementing or for whom. And we were specifically trying to look for MI and stroke. We weren't able to pull that out. Very few models included stroke patients because, well, stroke's hard. Stroke patients have cognitive impairments. We can't include cognitive impairments in these clinical trials. And of those that did, they weren't able to present findings for stroke patients because they weren't powered to do so. So there were significant gaps. We didn't know what we should be implementing for stroke patients. We didn't know which strategies, what interventions. So we went back to the healthcare providers and said, what are you going to do? They said, well, we're not being penalized for this yet, so we're not going to worry about it. So hospitals were so focused on heart failure and on MI and on pneumonia that stroke just kind of lay low, right? We're not going to worry about this for stroke. We're just going to keep moving in the practices that we are. So we went to the patients and we said, here are the strategies that are being discussed as being, evidence-based for other conditions. Were these part of your discharge planning? Some yes, some no, some, well, I'm not sure. What does that mean? I don't think anybody discussed that with us. Interventions were not tested, the same intervention was not tested across the different models, so we actually couldn't even say, that this was kind of a standard, or this is a bundle that we should be testing for stroke, because we didn't have that when we looked across the different models that have been tested to date. So when we had ultimately summarized our systematic review for stroke, at best we could say, well, there's been a lot of work done in other countries, and that's the work that was done in early supported discharge. So the model around early supported discharge essentially is supporting people from the hospital to go home with an integrated healthcare team, rehabilitation clinicians, nursing, a physician, to be able to do that follow-up, minding the gap, and to be able to support them, answer those questions, especially in the short term, being able to do intense rehab in the home. But none of this work has been done in the US. So we had proposed a framework for transitional care based on the literature that we had for stroke and for MI. And what this has done in working with our patient groups and many national and international organizations is, after spending so much time disseminating this internationally, we have, right now, PCOR just invited us back on this last LOI to submit a full proposal for a CER study for transitional care for stroke. We have another LOI that was just approved for an ESD, an early supported discharge pragmatic trial in the US. And again, that's built off of the integration of different data sets, and now hospitals saying, you know what, we know we're not doing this well, we could do a better job, let's test this intervention that's worked in other countries and how to adapt that here in the US. And globally, so here comes the China Medical Board and some of the other funding, we have moved this work into implementation research. None of these models are going to work in resource-poor nations or communities, so we're doing this work in China, in Peru, in India, and so these global adaptations of ESD have really formulated out of partnerships with the medical organizations, the professional organizations, often the ministries of health, because if they're not behind it, it's not going to happen. And then ultimately, all of these are being done to be able to generate recommendations to improve practice. So even among the trials and the CER studies that we're doing, we have strong evaluation components so that we can be able to examine how they're being implemented so that we could more readily implement them in our next set of sites. At the same time, CDC that had commissioned this systematic review, this HTA through AHRQ, they then, because of these findings where we said we really don't have the evidence we need for stroke, they then funded 3 states to evaluate the translation of evidence in implementation-based models. So there are 3 states that are funded, Ohio, Michigan, and Massachusetts, to be able to look more closely at what integrated health systems and what hospitals are doing to support stroke patients that are discharged home. So I'm the transition care specialist for one of the 3 states. And what's been fascinating about that work is how each of the states has gone at this a little differently. So we're all finding some very unique things to the state. And a lot of this is being driven out of local policies that we didn't expect and CDC didn't expect either. But all of this contributing, again, into a larger registry that we're going to be comparing outcomes on across the 3 states. CDC funded, and the intent, again, is to be able to recommend changes to policy. So the landscape at this point, there's so much attention on transitions and these handoffs from so many organizations. I mean, National Quality and Innovations, it just goes on and on. Specific transitional care initiatives, it was astonishing actually to learn how much has been dedicated just since 2010. And the opportunity for us specific in Ohio, we were already working with 44 hospitals, so to be able to go to them and say, we have this great opportunity and we've received funding to work with you to be able to improve the care that you're delivering. So we developed a state-level stakeholder group, and we have 75 organizations and 144 people that meet quarterly to continue to talk about how do we better do this, how do we study it, and then the work is primarily being driven out of the hospitals, and then they deliver that work then with their partners. The stakeholder input, one of the first questions we'd asked them was, if you could put all of your eggs in one basket, where would you aim improvement efforts for stroke? And we just left it open like that. So some were still focused very much on pre-hospital care coordination, some on specific patient outcomes, readmission function. Some wanted to really focus on education, some on risk factor modification, but surprisingly, that they were recognizing that at least where policy was going, the majority of people at that meeting had said, we really need to do a better job of addressing care coordination. Our whole hospital's paying attention to this, and stroke's not included in these discussions. And if we could do that in this group, then we'd be ahead of the curve. From a patient perspective, we asked those hospitals then to go to their own stroke survivor groups and use the same survey to get some feedback on where did they feel the biggest gaps were in their transitions. The feedback was largely around discharge instructions and follow-up and medication instructions. So the interventions themselves that we've decided to implement have been based on these feedback. I close with these last two slides because I still find it striking when we talk about how to involve patients and stakeholders in our research continuum. There's kind of this, well, we know where to do this, but how to do this, because do you really bring them into the discussion with the statistician? I get that a lot. Well, I can't imagine the physician of the group having the same discussion with our research team if the patients were there. That one came up a lot. And there has been kind of a training component of really being able to work with the patients and the caregivers that are coming in to, in advance, describe who's going to be in the room, talk about the study, and have them understand the intent. But we have used this model that actually came out of a city initiative that's between the FDA and Duke for improving clinical trials of thinking about and working with patients and our stakeholders at every step that we can throughout the continuum of research. Right from the beginning, from developing the concept, having them choose the outcomes, having them choose if it's interventions, how we prioritize those interventions, whether we stepwise or otherwise, all the way through to dissemination. And it has just been so rewarding in that you just feel that it has the meaning that we may not have had otherwise. Changing anything from the order of survey questions to I would never ask it that way. If I received that question, I would leave it blank. Like it's been really intriguing to have that kind of input, particularly now as we start doing more prospective work. This is my favorite slide from City that I wanted to close with, because when you start, it says begin here at the top. When you ask yourself, was the research idea from the patient community? Well, no, this was something that came out of our research team. Well, have you asked your patients what they think of your research? Well, no. Well, have you considered being an accountant? I mean, isn't this why we're doing this work, right? And I was really fortunate to be a part of some really strong research teams, especially through my training. We were always very connected to either health systems or to clinical health services. So even in the classes I teach, and we were talking about this, some of us earlier, even in the classes I teach, I'm sure that I ensure that all their student projects are health system-based projects. And it's just really important to me that we're engaged that way. I could be an accountant, I love numbers, but that isn't why I do this work. And so to be able to go through this and think through, well, is it meaningful? And where are they being involved? And ultimately, being able to get to this last block, patients need more researchers like you as partners. That this really is meant to be a partnership, that we're not going to them, going to a community and saying, what is it that you need, and then walking away, and then delivering the results later. But it's a continuous discussion, and that we are being seen as partners. So these patients and non-research stakeholders really being a driving force in clinical research, and how do we just make this more the norm, and not just responding to calls for funding. Aligning with national and international priorities has really increased the significance, I think, of the work that we're doing. And being able to always link this back to, I was describing, if we're doing work in the health system, we always link it to the balanced scorecard. If we're doing work, if we're proposing something to do with research, we always link it back to a national priority, or international at this point. and being able to increase meaningful engagement of patients across the research continuum, because we know at this point it's been more effective, it's definitely been more enjoyable, we've been more efficient, and we've been more productive. So I'm happy to take questions and hopefully open the dialogue to hear some other people's perspectives. So thanks for having me.
The 40% of the patients ended up going home after the inpatient admission for stroke.
Almost 50, yeah.
Did you see a geographic variation in terms of, the percentage? Because I'm just wondering whether what is driving that is the state-by-state variation or region-by-region variation in the availability and access to either inpatient rehab facility or nursing facility.
So some of it, we expected some of it to be explained. We expected more of it to be explained by access to those inpatient services. But what's been really useful is we're using an instrumental variable for distance from the hospital to those facilities. And it's not explained, so we thought we'd be able to explain away some of those differences, and it's not always the case. So access isn't always the primary reason people are going home without services. So now we're thinking, if people are going home without services, are they the right people to be going home without services? And that's what we're trying to understand. So it does explain some of it, just not all of it. Good question. Yes?
You admit stroke is a very diverse group of patients, very large numbers. In selecting a group of participants, stroke participants, is there any safeguards to help ensure that it's a representative of people with stroke? I mean, I was just wondering, could it be possible that people that just come to those, events like this are, of a particular mindset? Just in this kind of research in general, are there means to help ensure you're getting a representative sample of people with stroke in your focus groups?
You're saying for input and involvement? Mm-hmm. Not. So somebody I think had asked this earlier today, and here's how I have differentiated it so far. So I came from public health when I came into rehab. And I think at this point, I'm not studying patient engagement, right? So I just want to be sure that we have people involved. What ends up becoming important is, for me, that I'm not trying to have those that are involved in the research design and our discussions to be necessarily representative. I find their experiences to be as meaningful as anybody else's. So yeah, would it have potentially been shifted somewhere else if we had different people? Possibly. But this is why we keep going to so many different groups and why we've been sure to engage. Particularly, the American Heart Association has an amazing network. So with all of our hospitals, we've asked them to engage their survivor groups, so prior to dissemination and linking in with them. But just for involvement in our research study teams, not all people can immediately be placed into that situation. And so we've had to work, there are training sessions and preparing patients and advocates for participating in research teams, and there are discussions to be had. It can be very intimidating to potentially have been in the room with a physician that you might have had. So there's a lot of preparatory work, and where I'm not studying patient engagement, we just wanted to be sure that we had input, and then through the process we check in with different groups. But it likely isn't representative, but that wasn't our goal. Other people have that goal in their research, but it wasn't ours. It's a good point. Yes, please.
Do you have any comments about the potential role of the primary care medical home in transition and in rehab?
What kind of comments? I did that systematic review as well for ARC, so I have a lot of thoughts around that. And interestingly, I'm hearing more people now talk about the patient-centered medical neighborhood, because it's not necessarily just the primary care provider office anymore, and we can't always be thinking about services that are just co-located, because oftentimes we need to be sure that that primary care office needs to be linked to all the services that they need as well that aren't necessarily all in the same place. So yeah, I have a lot of thoughts on that. And we're not seeing those handoffs to be as strong. It's interesting now to see more funding streams directed to either patients that are being admitted or being able to manage those networks. But there's more evidence in that area than there is in the transitions directly. And there actually was a whole series of ARC reviews around patient-centered medical homes, how to implement them, how to study them, and where that work is going. Yeah,
Yes, I'm Dwayne Moore from the Department of Nursing.
great.
I come from a background on home health in North Carolina. And I was wondering to what degree, in looking at your gap, the degree of influence that pay sources would have in this immediate discharge, because there is that drive under the ICD-9, ICD-10. CVA patients only have this many days regardless you discharge them. Have you looked at that variable?
Well, we can't look at it with the Medicare data because Medicare fee-for-service are all the same. But that's why it becomes so important that we start linking with other data sources. So we are doing it in North Carolina, linking with a lot of the insurers and with some other state data and with the state health insurance plans. There is some variation, but for those patients that are going directly home and the ones that you were asking about, now that CMS has this transitional care code, we're really trying to, particularly right now, to promote people to be immediately connected to a provider that can bill for somebody to be seen. So even the ones that are going home, if they can be seen within 48 hours, they can bill for that transitional care visit. Some of the people that are coming back to the emergency department because of something emergent can still then be admitted to a skilled nursing facility within 30 days of their hospital discharge. So trying to better understand all of those other things as well as the early discharge becomes a little complex and somewhat patient-specific. So we haven't been able to parse them out. So as we start to pull out these different trajectories, it's like, well, why did this patient do this one and these 10 over here do these ones here? And that's where I think studying within state and within multiple data sources across insurance is going to be so key. But we can't necessarily do it in Medicare alone. Yeah, it's a great question.
Okay, well, we'll maybe stop there because I know people have commitments at 2 o'clock, but thank you
Yeah,
very much.
thank you, and thanks for being here today.